Do you want me to just tell you when to forward the slides?
Yep.
Okay. So I'm just doing a quick presentation on the ADA Standards of Medical Care from 2019 on treating patients to prevent them or delay them from getting type 2 diabetes. You can skip ahead. And this is just what the ADA, the front page looks like, just for a reference for you. You can go ahead and skip that. So when you're screening a patient with who you think may have diabetes or prediabetes, you actually want to check at least once a year. And those are the ones with that you're more concerned with. So there are risk factors we screen for, and I'll show you that in the next slide here in a moment. And then the ADA does have a risk test. You can actually, it's like a number chart. You give a point for so many things, and it'll tell you those patients who are at higher risk. So we already know the ones that are at higher risk are the ones who have prediabetes, and their A1Cs are generally between 5.7 and 6.4. They have impaired glucose tolerance tests or impaired fasting glucoses. Okay, you can skip ahead, Caitlin. So this is just a list of the criteria for testing diabetes or prediabetes in patients who may be asymptomatic. So it's the overweight or obese patients, and the ones who have one or more of the following bullets that are listed there. So first-degree relatives, high-risk ethnicities and race, history of cardiovascular disease, hypertension, cholesterol, PCOS, physical inactivity, and any other conditions that might be associated with insulin resistance. Also those with the A1Cs that are a bit elevated but not yet at the diabetic range. Those you should at least test yearly. And then women who had gestational, you want to test them lifelong, at least every 3 years. Patients over 45 patients should begin testing at over 45. And then if everything's normal on those tests, you want to just consider testing them every few years. And of course, more frequently if they have any of those other risk factors that develop over time. You can skip ahead. And this is just an example of that chart. I actually got this on the ADA website. So you basically score the patient based upon like different criteria. And it gives them a number at the bottom that tells you whether they're high risk or not. So it's a nice little tool if you want to get on the ADA website. Okay, you can skip ahead. So the prediabetes, as I discussed before, so your fasting sugars are between 100 and 125, or a 2-hour post glucose test between 140 and 199, or an A1C between 5.7 or 6.4. And to have diabetes, you actually have to have a fasting sugar greater than or equal to 126 after an 8-hour fast, or 2 hours after glucose tolerance over or greater than or equal to 200, or an A1 greater than or equal to 6.5. And then the other one is they actually can have just classic hyperglycemic symptoms and a random sugar 200 or higher. You know, if you are really not sure on this test, you want to repeat it at least once on 2 separate occasions or 2 separate samples. Or excuse me, you can use the same sample but 2 different tests. You can go ahead and skip ahead. So to prevent the progression, of course, lifestyle intervention is very important. So they do recommend trying to get someone enrolled in an intensive behavioral lifestyle intervention program. So it's modeled after the DPP program, where they were trying to maintain a 7% weight loss with moderate intensity activity up to 150 minutes per week, as well as, you know, their dietary modification. So with this guideline, they do say that you can use technology-assisted diabetes prevention interventions, and that may be also effective in preventing the progression. It's cost-effective in the end, but sometimes third-party payers may not pay for those classes. Sheree, have you found that, like, when we're trying to do diabetes education, a lot of times insurances won't cover, which is probably the most important time to educate, but okay, you can skip ahead. So along with this diabetes prevention program, of course, like I said, the lifestyle, behavioral therapy, and individualized reduced calorie diet has been shown to help with not only the prevention of diabetes, but blood pressure, lipids, and inflammation. In this DPP study, it showed the reduction of diabetes type 2 by about 58% over 3 years. So that's like huge. And then other studies along the way have shown that, yes, you can still continue to reduce the incidence of developing diabetes if you continue this kind of therapy. You can go ahead and skip ahead. So the two goals intended include achieving and maintaining 7% of weight loss, and number 2, 150 minutes of moderate intensity activity a week. So they tried to get you to lose the 7% within the first 6 months, and then if you would lose up to 10%, you're going to get your maximum prevention. About a 1 to 2 pound a week of loss a week is ideal if they can maintain that. So usually what I tell patients is just figure out how many calories you're taking in a day at present on average, and then that's sort of your set point. And then I tell them, if you cut out 500 calories a day, that's times 7 days a week, that's 3,500 calories, and that's about a pound. So if someone's not eating as many calories, that would be a strict reduction. You might have to go about it a little bit more slowly. And then as far as the exercise, they recommend, moderate activity, intensity activity, like brisk walking. You can replace some of the 150 with the strength training up to 75 minutes a week, and at least 3 days a week, 10 minutes with each session. And, they don't want you to really skip more than 2 days between exercise. You can go ahead and skip ahead. So nutritional support, of course, that's, ongoing, but also sometimes it might be beneficial to try something like metformin or some pharmaceutical agents that might help or assist with weight loss. The Mediterranean diet is something they went back to a lot, where it's low calorie, low fat. I thought it was kind of interesting, though, all our patients, we usually try to do lower carb if you're trying to lose weight and keep your sugars under control, but there's really not enough research out there stating that low carb does prevent the progression to type 2. I still do recommend it because I think, with higher carb, you're getting usually more fat content anyway, and it helps with the weight gain. So I do try to stick to lower carb, low calorie, low fat. And that's things like, goods in the picture: berries, nuts, fish, white meats, grains, whole grains, and minimizing the processed foods. You can go ahead and skip ahead. So improving activity can improve insulin sensitivity and reduce abdominal fat. That's been shown in young children and adults. Aerobic activity, resistance training, all good. And just breaking up sedentary time seems to help lower prandial glucose levels. Go ahead and skip ahead. So using technologies, so the CDC did certify technology-assisted modalities as effective vehicles for this DPP-based interventions. And I put the website on there, so if you wanted to refer to it, it basically tells you how to get this set up. They have to use an approved curriculum, include an interaction with a coach, which could be a virtual coach, and they have to meet their outcomes with participation, activity, reporting, and weight loss. And they even said using things like smartphones, web-based applications, and telehealth are all fine. Go ahead and skip. So the other thing is that smoking may increase your risk of type 2, so just make it a point at every visit to ask and advise and keep assessing and try to help them to quit smoking in any way you can. Go ahead and skip. Metformin therapy, so for the prevention of diabetes, it should be considered in those with prediabetes, especially those with a higher BMI or less than 60, or women who's had gestational diabetes. It is not approved, though. It's all off-label use. I mean, as a nurse practitioner, I know, we're not technically allowed to write off-label. Do we do it? Yes, under the doctor's supervision, of course, but it is something to consider. And you want to balance your risk-benefit in terms of pharmacological type therapies. Metformin's been around a long time, and it has a lot of long-term safety studies, so as opposed to other oral agents, so this would be my first go-to. Some people have tried Actos as well. Okay, you can go ahead and skip ahead. So we also want to prevent cardiovascular disease, and just to do that, you just want to look at the modifiable risk factors like their blood pressure control, their lipid control, and of course the smoking. You can go ahead and skip. So these support programs, oops, back one. Let me miss one. Okay, go forward one to the last one you were at. This just talks about the benefits of diabetes self-management education. These bullets are in the ADA, on the ADA website. Okay, go back to the last slide.
Okay.
There you go. Okay. So basically, diabetes self-management education and support programs could be appropriate for people with prediabetes to receive education and support and to help them maintain their behaviors and, of course, delay the diabetes development. And like I said before, this is kind of redundant, but sometimes reimbursement is a barrier, but still strive to help patients with that. Sometimes, people travel long distance to get to us, so I will look for like other sources or diabetes educators local to their area, and sometimes they have support groups that have nutritionists or dietitians who participate. So those are good ways. You may just want to check at your local hospitals or different centers around the area. You can go ahead and skip ahead. And that was, okay. You can skip just one more, I think. That's really all I have. Does anybody have any questions?
This is Jen. I have a question, which I know for people who have been on since the beginning of this endocrine echo. I asked this in the beginning too, but it's still a question for me. So if somebody doesn't have any other risk factors for type 2 diabetes, but they're on a high intensity statin, say for high cholesterol, or let's say they have cardiovascular disease with no diabetes, how much does the statin change their risk for type 2 diabetes?
I don't really have any studies showing the statins reduce the risk of cardio or the development of type 2 diabetes. It's more, I guess the reason we treat diabetes is to prevent the problems from it in terms of cardiovascular prevention. So I think it's like the opposite. So get your diabetes, prevent that so that you don't develop cardiovascular disease.
Okay, so the statin in and of itself isn't a risk factor for developing type 2 diabetes.
Being on a statin?
Pardon?
You mean being on a statin will increase the risk? There may be some things out there, but there's nothing solid enough to really tell us not to give statins. So if they have cardiovascular disease or they need a statin to bring their lipids down, I would treat it.
Okay.
There's nothing out there that I know of that's solid enough to say you wouldn't use statin therapy if they need it for, hyperlipidemia.
Okay.
Do you know of anything, Sherry? Have you read anything on that? Yeah. Yeah, like Sherry said, really the benefit of statin therapy will outweigh your risk.
Great. Were there any other questions today, everybody? I was super glad to see some new people. That's great. All right. Well, then we are going to call it now. Our next session is on March 13th. I will, of course, continue to ask for cases and everything like that. Let us know if there's anything you need to hear about, any questions you have, and I'll go ahead and forward those along. And thank you, everybody.
Thank you.
Great.